Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center along with the Population Institute for a panel exploring lessons from Africa, building resilience through community-based health systems. I'm Sarah Barnes, and I'll be your moderator today. I direct the Maternal Health Initiative and lead the Women and Gender work at the Wilson Center in Washington, D.C. For those of you who are unfamiliar with the Wilson Center is a living memorial to President Woodrow Wilson and a critical source of nonpartisan foreign policy research and analysis. Today's event is the result of the collaboration between our partners at the Population Institute and 3 Wilson Center programs: the Maternal Health Initiative, the Environmental Change and Security Program, and the Africa Program. The Maternal Health Initiative focuses on decreasing maternal deaths, as well as issues related to global health and gender equity. The Environmental Change and Security Program explores the connections between environmental change, health, and population dynamics, and their links to conflict, human insecurity, and foreign policy. And the Africa Program works to address the most critical issues facing Africa and US-Africa relations, as well as enhances knowledge and understanding about Africa in the United States. This event's discussion is at the intersection of these program objectives. Today's event is not just about the response of African countries to the COVID-19 pandemic, but as in all health-related discussions taking place, COVID-19 will be a central point. What we really hope to tackle today is how community-based health systems have played and can continue to play an outsized role in the success and health of a country. What lessons can those of us focused on health take with us from this discussion? And which African countries are leading in the response to COVID-19 and how? The current pandemic has revealed shortcomings in the health systems of countries all over the world and has exacerbated existing inequities. In sub-Saharan Africa, the health crisis threatens to severely curtail already limited public health services. Yet, despite immense hurdles, past crises such as the Ebola epidemic have shown that innovative decision-making and locally led interventions can go a long way toward improving the resilience and responsiveness of health systems. Some experts in the US and in other places have pointed to lower rates of infection and death due to COVID-19 in African countries as a sign that the continent is faring better than much of the world. But the situation on the ground may be more complex. And that complexity is exactly what motivated us to bring together this group of eminent panelists today. To add to that complexity, I would just like to add here that Africa is not a homogeneous continent, and there is much diversity and disparity between and within its countries. We will do our best to bring that out in our discussion today as well. Now I'd like to just take a moment to thank all of our panelists for taking the time to be here today, and to thank our partners at the Population Institute for your continued support, as well as my colleagues at the Wilson Center for your collaboration on this event. And before we move to today's speakers, I'd like to remind the viewers that there will be a Q&A after the panel presentations and discussion. So please send your questions to ecsp@wilsoncenter.org, and we'll do our absolute best to get as many questions to the panelists as time allows. Again, you can send your questions via email to ecsp@wilsoncenter.org. Please indicate your name and affiliation with your submitted question. To kick things off today, it is my absolute pleasure to welcome Ambassador Deborah R. Malik to deliver opening remarks. Ambassador Malik spent nearly 39 years representing the United States as a diplomat with the Department of State, working primarily in and on Africa. Until January 2020, she served as ambassador to the Republic of Uganda. Prior to that assignment, Ambassador Malik served as the ambassador to the Republic of Liberia, where she led the US on the ground response to the Ebola epidemic. Ambassador Malik, welcome. The floor is yours.
Sorry. Good morning, good afternoon, good evening to our participants. Thank you again to the Wilson Center and the Population Institute for the opportunity to participate today. I look forward, like all of you, to hearing from the panel members about a very important issue, a topic I think that we could discuss for days, and certainly will continue to look at in the coming months. I have seen firsthand the impact of disease outbreaks, unexpected disease outbreaks on fragile health systems, not only in Liberia when Ebola struck, but also watching in Uganda as they worked to ensure that Ebola did not come across the border from the Eastern DRC when that outbreak occurred. We have a lot of work to do, and we learned a lot of lessons in terms of how we can respond when disease outbreaks hit. And what we learned firsthand in Liberia was that it requires a collective effort. It cannot be one actor, one person, one entity that responds, but very much of it is dependent on collaboration and cooperation, but most importantly, leadership, clear communication of messaging, and ensuring that you have not only infrastructure, but that you have personnel and other resources on the ground to be able to address the problem. We also know that it's much better to do the prevention work up front, to invest in those systems, invest in those resources, invest in the people and the personnel that are needed to avoid allowing disease outbreaks to become a problem and become a pandemic. So certainly, unfortunately, the lessons that we did learn during the course of that fighting Ebola in West Africa, where it had not been seen before, seem to have been ignored in many cases outside of Africa. But it's been interesting to watch how the countries on the continent have responded to the COVID outbreak, demonstrating to us that they have actually learned some of those lessons and have taken capacity building and utilize that has been funded by the US and by other partners, and used it effectively to try to counteract this current pandemic. What it has really driven home to me, starting in Liberia, but certainly watching over the ensuing years, the development of initiatives such as the Global Health Security Agenda, is that there really is a fundamental importance that investments in healthcare from all streams, investments by local domestic governments, investments by the international community, investments by foundations and other sources in the health sector, because it underpins so much of development and economic growth and prosperity and futures of countries. We saw in Liberia just how perilous the economic situation could become with a disease that was running unfettered in some cases for several weeks and months inside the country. It wasn't really until afterwards that we knew just how close we came to having complete economic collapse in that country. And so you can't just talk about the health sector and health systems in isolation. And one of the things that became very apparent in the course of the work in responding to Ebola is the need to ensure that you have not just national level systems, but that you have community-based systems in place as well. And I know we will hear from the panelists about their take on this issue and the fundamental nature of how we can best take advantage of ensuring that information is disseminated, that people receive basic health care, that you can use community level workers to be surveillance and sentinels for identifying when disease outbreaks happen, which then allow systems to respond more efficiently, effectively on the front line while things are still small enough to contain. So I left my experience in Liberia and then moved on to Uganda and began to see the advantages of the types of investments that are being made, where public health capacity is integrated into the health system. So it's not just about creating health systems that provide health care, It's providing mechanisms, creating labs, creating systems, creating data information systems to allow the grassroots and the communities to be connected to the center. And so I think what has become apparent is that we need to continue those investments. We need to encourage governments and entities to continue to invest and to prioritize these types of investments. Unfortunately, that isn't always the case in many countries. And we need to figure out how we can ensure that people understand that without health systems that function, without sufficient healthcare workers, without data systems, that it really isn't possible to talk about building economic prosperity for societies, because we know women and girls in particular are often disadvantaged when there is no access to healthcare. They're the first ones to lose out. They don't necessarily, and children who don't receive good healthcare, who are poorly, have poor nutrition, do very poorly in school and really don't realize their potential. There's a whole host of other issues related to this. But I do want to highlight, the work that Uganda, for example, has been doing in the face of COVID-19. They took very early and decisive action. They are using tools and capacity that have been developed over the last number of years to respond, to surveil, to watch their borders, to do testing, to do contact tracing. Some of these elements that we saw worked in Liberia, worked in Sierra Leone, worked in Guinea, and somehow we haven't put some of that to work here at home, other than in isolated parts of the country. So it's nice to see that they have been able to control the levels of cases. They are isolating people when they test positive, or forcing or making sure that people are self-isolating. And I think it's a direct indication of the commitment on the part of that government to ensuring that they take the capacity that they worked on, that they understand the importance of public health. Finally, I just want to say that, it really is necessary that these health systems be integrated and that they take a holistic approach. So we know that interventions that address nutrition and education and early access to healthcare will help, for example, reduce the prevalence of spreads of diseases like HIV/AIDS. And so you can translate a lot of those kinds of wraparound programming and institutions and systems will work in other instances as well. I don't want to go on too long because I really do want to hear from the panel, but there's a huge opportunity, I think, across the continent of Africa to help encourage those countries to continue to invest in their health sectors. Importantly, to continue to invest in community-based mechanisms. Community health extension workers, community health teams, different models are out there. But we know what works because people will respond and do what they need to do, whether it's behavior change, listen to health messaging, if it's coming from people that they know and trust who are part of their communities. So thank you again for the opportunity to be here. And I look forward to the discussion and hearing from our distinguished panel members. Thank you.
Thank you very much, Ambassador. You've definitely teed us up for a very interesting conversation, and I look forward to chatting with you more at the end of the program for the audience-led Q&A. So today's panelists will share, as Ambassador Malik mentioned, their thoughts on the role community-based health systems play in responding to health crises. We have 4 great speakers here today, and I'd like to introduce them all at once. And I just ask each of you, as I introduce you, just wave in your Zoom box so people know who you are. First, we have Dr. Mohammed Abdulaziz. He is the head of the Division for Disease Control and Prevention at the Africa Centers for Disease Control and Prevention, Africa CDC. He is a trained medical epidemiologist and coordinator for the Africa CDC's Regional Integrated Surveillance and Laboratory Network. He's a medical medical doctor and specialist in psychiatry, and he is zooming in today from Ethiopia. Next, we have Dr. Uzma Alam. She is a senior program officer for Deltas Africa and the Alliance in Accelerating Excellence in Science in Africa. Dr. Alam holds a master's of public health from the Yale School of Public Health and a PhD in microbiology and immunology from the University of Maryland. Alam's research is centered on infectious disease and healthcare delivery in the international development and humanitarian context, where she applies data to inform and influence policy and global health programs. She's been deployed to the front lines of outbreaks across the African continent and has worked to combat Ebola, measles, cholera, and other infectious diseases. Alam is a COVID-19 Community Response Committee member reporting to Kenya's Ministry of Health. And next is Dr. Julia Nabyanga, a medical officer in charge of health policies, strategies, and governance at the World Health Organization. Dr. Nabyanga is also the team lead for health financing and investment for the universal health coverage and the life course cluster at the WHO, and is based at the inter-country support team for East and Southern Africa and Zimbabwe. Dr. Nabyanga has her PhD in public health and previously worked as the regional advisor on health systems partnerships, monitoring and evaluation based at the WHO Regional Office for Africa in Congo, Brazzaville. And finally, we have Dr. Raj Punjabi, the CEO of Last Mile Health and assistant professor of medicine at Harvard Medical School and the Division of Global Health Equity at Brigham and Women's Hospital. He grew up in Liberia and fled the Civil War with his family when he was 9 years old, becoming a refugee in the United States. He returned to Liberia as a medical student and went on to co-found Last Mile Health in 2007, a nonprofit organization that partners with countries to design and build community-based primary health systems that currently operates in Liberia, Malawi, Uganda, and Ethiopia. Last Mile Health trains and supports teams of community and frontline health workers to bring life-saving services from vaccines to maternal and neonatal care to the doorstep of people living far from care. So we have an incredible group here today, for sure. So we're going to go into this next session and have each of the panelists give some opening remarks about the role of community-based health systems. So first, we're going to go with Dr. Juliet Nabyanga from the WHO to make her opening remarks. Juliet, welcome. The floor is yours.
Thank you. I'll share my screen.
Great.
Okay. Thank you so much for inviting WHO to this great meeting that will be discussing building resilience through community-based health systems. I bring apologies from Dr. Maweti, the Regional Director of the WHO Africa Regional Office, who would have loved to be here, but due to prior commitments, she couldn't make it. And I'm pleased to make this presentation on her behalf. My presentation, I'll touch on 3 issues. I will talk about the lessons we've learned from the Ebola outbreak that have informed our building resilience work in the WHO, but also our support to countries. Then I also talk about the resilience of health systems in the WHO African region. We cannot talk of resilient community systems without having resilient health systems, because community systems are part of the health system. So after having done so much, I will talk about where are we. And this is the data as recent as 2018, where we've assessed the resilience of health systems in the WHO African region. Then I'll go on to touch on a few examples on when we talk of resilience, what have we seen in the COVID response? So I want to start with the lessons from the Ebola outbreak, West Africa mainly. And I think what have we learned? That we need to see the role of communities differently, from recipients of services to people at the forefront. So they have a fundamental role to play. And now we talk of a community-led response. So we've moved from risk communication to risk communication and community engagement. And indeed, we appreciate that really communities play several roles. They serve as a link between the community and the response team. And this is important for building trust, to which enhances the uptake of interventions and the IEC messages we take out, we send to communities. And a few examples, of course, Ethiopia, and I could say the same of other countries, they've played a fundamental role in the COVID response. They've been instrumental in risk communication, contact tracing, transportation of supplies, ensuring continuity of essential services. And I could say the same of the Marburg response in Uganda, the Ebola response in DRC. We've seen communities playing a significant role in supporting response efforts. But we also note that their roles are diverse. They are not only restricted to response to diseases, but also other disasters. For example, the cyclone Idai in Mozambique, where they were instrumental in providing first aid, saving people from drowning, but also taking people to safety. Now, what have we learned? We've learned that they are enablers. And these really define the variations we see in the functionality of community health systems. And when we talk of enablers, closely related to that is the role of governments in building community systems. They need to set up the structures, they need to capacitate them in terms of training and tools, and also incentives. And of course, we've learned that we need to pay attention to cultural issues, traditional issues, religious considerations, because these have to be factored in the response, but also in the messages we send out. The role of traditional leaders, these are trusted by the communities, and we need to put them at the forefront when we want communities to engage with our services and to uptake interventions. So these enablers define the variations in functionality that we see. And again, moving, even us as the WHO regional office, we've learned from that now social workers and anthropologists are part of the response team to help us understand the communities better. What is it that will work? What is it that will not work? Now, I want to turn to resilience of health systems. Where are we? And of course, when we talk of resilient health systems, we are looking at systems that can detect, that can respond to any shock, any outbreak, but even within that, sustain the provision of essential services. And that's when we say health systems are resilient. So we've assessed there is inherent resilience of health systems in the WHO African region. And what did we look at? That they must be aware, and there we are talking of information systems that are able to identify, that are able to report, that are able to monitor. And we're also talking of the capacity of systems to diversify the provision of health services. That if there's a new event, we can have the diversification of the range of services, the organization of services. We talk of triage, the skills of health workers to provide services even beyond the normal essential packages they've been working with in order to respond to and also isolate the new event. We are talking of capacity to mobilize resources to respond. We are talking of continued learning and adaptability as they are challenged beyond the norm. And these are the parameters that we are put in the assessment, and they were compressed in an index, where you have the lowest score of 0 and the maximum score of 100. We see variation across Africa. But the key message here is that we still have a lot of work to do, because out of the maximum 100, regional average is only 49. And 24 out of 47 countries scored less than 50. Of course, we have countries that are way down, like Congo and Gabon, where the score is less than 10. And this tells us that we have done so much, we've learned so much from Ebola, and we've done that, but we have a long way to go. And we have data corroborating some of these findings. For example, the capacity to provide intensive care. And we look at intensive care bed capacity, where we have a regional average. Sorry, it's covered on my screen. We have a low regional average, which is, sorry, the panel is covering my, thank you, is only 3.1 beds per 100,000. And this is against the 11.5 per 100,000 that we see in European countries. So this means a lot of work still needs to be done. Now I want to move on to the COVID response. When we talk of resilience, what have we seen? And I'll give only 2 examples, and then I'll wrap up my presentation. And I want to start with the financing for the COVID response. What does it mean? That if we talk of being aware, we talk of readiness, which means the financing systems must anticipate that shock might arise at any time, and they must set aside contingency or reserve funds. But what do we see? That in 26 countries, special funds had to be set up. Some set up 4, some set up 5. And we're not setting up these funds is a legislative process. It takes parliament. And of course, that impacts on how fast you can respond. So only 4 countries drew from reserve funds. We need to build that adaptability in the financing systems. What else are we concerned about? Funds must be on budget. They must be accounted for through the financial management systems of the country. But out of the 26 funds that were set up, 22 were extra budgetary, were off budget, and indeed set up the special accountability process. They had variations in how fast they can send money to the subnational level where actually action takes place. So we are also talking of financial management systems that have that inbuilt flexibility and adaptability to account for any funding that is raised by the government. Now, this will be my last slide, and I want to touch on the issue of coordination. What have we seen when we talk about coordination of the COVID-19 response? Several structures were set up at the national level, at the subnational level, at also a sector level. And indeed, we've seen best practices, but also challenges in the coordination of the response. The best practices, we've seen political leadership taking charge of the response. And this is something we've always craved for because it's important for health sector development. It's important for UHC, not only the response to emergencies. Strong multi-sector collaboration. We've had challenges getting this going, but we've seen interministerial task forces playing a fundamental role in the response. And we've realized the whole government approach, which is important again for any other health sector process. We can talk about antimicrobial resistance, UHC, and so on. The strong involvement of the private sector is really, really commendable, especially in financing. In service delivery experiences are varied, but they've played a fundamental role in kind contribution, financing, and we need to build on that as we build resilience. But also we've seen challenges because routinely health sector development in any country is coordinated by Ministry of Health structures. And these have been sidelined and where coordination structures are set up at a higher level, they've been undermined. We've seen varied performance in multi-sector platforms, which maybe partially is understandable because of varied priorities and varied areas of focus. But also, we've had challenges in ensuring a coherent coordination process. Partners competing for recognition and attribution instead of coordinated response. Weak capacity to rally actors around a common direction, especially at the subnational level. And there's so many coordination structures that were set up, especially at the national level. Some countries had as many as 8, as many as 5, and the terms of reference were overlapping mandates, which caused friction in some of the countries. Now, when we talk of resilience, we are talking of consolidating best practice as the new norm, at the same time, mitigating the challenges. Thank you so much.
Thank you, Juliet. That was incredible. I just have a quick follow-up question for you. From your experience, what are some noteworthy examples of the health system's resilience when confronted with a public health crisis?
I think we've learned so much. One is that building resilience will take more than investing in building blocks. We need to look at processes. Now, I talked about the financial managing system. That's not an explicit building block. Partnerships. So we need to look at the software, the processes, management aspects, coordination aspects as part of building resilience. 2, we need to recognize the role of institutions and actors. When we talk of systems being adaptable, we are talking about the actors themselves being adaptable because they make that. So we need to pay attention to the actors and the institutions. And 3, we need to view shocks differently because we've labored so much focusing on emergency response, disasters, but I think shocks, we need to look at shocks 2 ways, acute and chronic shocks. Even a human resource strike is a shock to the system, and that's not an outbreak. So I think if we have that understanding, then we need to look at building resilience differently, that it's a day-to-day event. You know, it's part of what we do, it's part of our day-to-day work, and we need to keep investing. So it doesn't give us an end, and we don't have to wait for a shock. We need to work at it every day. And if we have that understanding, then we need to appreciate that building resilience is everybody's responsibility because issues of human resource lie with public service, not Ministry of Health. When we talk of social determinant and so forth, we're talking of other line ministries. When we talk of financing health sector, we're talking of the Ministry of Finance. So actually building resilience is a multi-sectoral approach, and it's everybody's business. Thank you.
Thank you, wonderful. Now we are going to move to Dr. Mohammed Abdulaziz from Africa CDC. Thank you for being here today, Mohammed. The floor is yours.
Thank you very much. Let me just put on my slide. There you go. So good morning, good afternoon, and good evening to the distinguished participants of this video conference, depending on which part of the world you are currently in. Let us take a few minutes and discuss the role of community-based health system in responding to health crises from the perspective of Africa CDC intervention in the COVID-19 pandemic on the continent of Africa. I bring you greetings from Dr. John Nkengasing, the Director of Africa CDC, who is unavailably absent today. Africa has always depended heavily on community health workers for meeting some of its basic health needs, mostly in the delivery of basic clinical services in its primary healthcare facilities. Though the number of community health workers available for this function vary by country, we know that in times of health crises like the current pandemic and other outbreaks, these community healthcare workers can be very useful workforce in responding to an eventual control of the public health events. The African Union Head of States declared way back in 2017 that Africa requires additional 2 million community health workers to ensure sustainable health for all on the continent. So for community health workers, how do we use community health workers for COVID-19? In a recent perspective in New England Journal of Medicine, shows that community health workers live in the society and are therefore trusted members of the community. And the community members trust them to provide them with accurate information about public health events that might seem distant to them initially. For instance, when the COVID-19 was in China, people were curious on the continent why the world is so engrossed with COVID-19. But the closer it gets to the continent and the closer it gets to the country, the first source of information for most people in rural villages in the continent in Africa were the community health workers. The community health workers can quickly serve as a link between clinical and community-based services necessary for effective response to emerging infectious disease crises like the COVID-19. This and many more unique roles of community health workers can help reduce the total case count for this type of outbreaks. In Africa, most community health workers are local to the community and can be used for remote monitoring and can be very effective in the response to outbreaks such as this ongoing pandemic. Precisely because of the above, Africa CDC decided that the community health workers should play a pivotal role in its support to the COVID-19 response by the African Union member states. Community health workers community health workers in member states will be supported by Africa CDC to detect suspected COVID-19 cases for testing, contact tracing, and advocacy. A community-based solution which we feel is sustainable compared to what we saw at the initial phase of the pandemic, where some African countries actually recruited epidemiologists and were paying over 3,000 USD. We at the Africa CDC felt that it is sustainable and catalytic solution to a pandemic that may be with us for longer than we thought. In Nigeria, for example, some states were hiring epidemiologists and were paying upwards of 3,000 USD for contact tracing and other activities outlined above. However, Africa CDC is now supporting them with trained community health workers, additional to their existing community health workers, with a little above $100 per month compensation, which is actually in keeping with the national compensation package for community health workers. I listened to what Ambassador Malak said very carefully, and we need to mainstream public health response to the health system. If you can use train a community health worker to perform all of these functions effectively and efficiently, and use the existing country policy of compensation, which for Nigeria is just about $100. Why do you need to bring people and pay up to 3,000 USD? That was done initially because it was thought that the outbreak would be for 3 months, but we now know that we will be in this outbreak or pandemic for a lot while longer than that. And the best and sustainable and catalytic way we can respond is to use the existing health system. To scale up the process I just discussed on the continent as a whole, Africa CDC will engage existing community health workers across all member states, while enabling committed countries to invest in scaling up that cadre, with the hope that this will help the continent to achieve the extra 2 million community health workers needed for sustainable growth, sustainable health, as envisaged by the head of state. We will support the training of 100,000 CHWs on testing, tracing, and treatment for COVID-19 response, and supply them with sufficient PPEs for safety operation. We also hope to support some countries with uptake of more community health workers if they demonstrate the capacity to retain them post-COVID-19 outbreak. All of this at the end, we hope will serve as the catalyst to closing the gap in the number of community health workers across the country as envisaged by the head of state. With the support of the Commission and some partners, we have already deployed nearly 8,000 community health workers across the continent and hope to increase this number to over 20,000 very soon. These are some of the things we are using from the lessons we learned from Ebola, and ensuring that public health response is mainstream into the health system of the countries in a sustainable way that can respond for a much longer period than what we currently have. Thank you very much for listening, and we'll be happy to take questions later. Over.
Thank you, Mohammed. I just have a quick question to follow up with you and continue the conversation around COVID-19. What kind of coordination do you think is needed across different levels of decision-making to stop the spread of COVID-19?
That's a very good question, because we know that the level of government that is closest to the response, where most of the action takes place, is the sub-national level. But that sub-national level may not be the level that has some of the best expertise, which may be available at the national level. Therefore, there needs to be good coordination between the sub-national level and the national level. And this coordination mechanism and framework should have happened prior to outbreaks like this, in which you have written protocols on how this coordination, sharing of information, sharing of data, and how to, for the national level, will be useful to the sub-national level. In the context of Africa CDC, we have another layer, which is the continental and even the international level, if, as you may speak. The continental and international level have access to guidelines, best practices, and see the overall perspective comparing data from different countries. And it's important that mechanism exists in which I know WHO guidelines, Africa CDC guidelines are being rolled out, but mechanism should exist in which those guidelines can be taken up by the member states and translated up to the sub-national level for effective outbreak or pandemic control. And it should be both ways, the feedback also to the top and then back to the member state. Thank you.
Thank you. Thank you. That was really great. So now we're going to turn to Dr. Uzma Alam from Deltas Africa and ASEA. Welcome, Uzma. The floor is yours.
Thank you, Sarah. If you just give me a second, I'll share my screen.
Absolutely.
So, good morning, good afternoon, good evening to our participants, depending from where you're joining, and a big thank you to the Wilson Center for hosting such an important event. Within the next 10 minutes, I'd like to discuss how data and communities make a powerful partnership when it comes to building resilient health systems. So just to put into context the landscape in which COVID-19 started unfolding in Africa. Africa has more than 20% of the world's disease burden. This is mostly infectious diseases, but we are undergoing an epidemiological transition towards NCDs. 90% of our food is from the informal food markets, not to forget that a large swath of our population actually works within the informal sectors. 1 in 3 Africans live below the global poverty line, and linked to this is 70% of our population living in informal settlements. We do have weak health systems, as alluded by to the previous panelists. We do have a rural-urban divide with large rural areas that are low densely populated and where our elder community members choose to live. We are a youthful society and we have a low mobility index whereby the 5 busiest airports in Africa equal only the 5th busiest airport in Europe. Not to forget that Africa hosts 27% of the world's displaced persons. And at the time the first COVID case was reported in Africa, Africa already had 69 other public health emergencies ongoing. And these included measles, Ebola, and cholera outbreaks. So for colleagues and I at the Africa Data Initiative Project, who all happen to be diaspora, it was very important to map out what the drivers would be for COVID-19 within the African context. But beyond this, it was more important for us to provide actionable research that health systems could use to deploy their programs and policies within their restrictions, and in doing so, develop resilience. Modeling COVID-19 in Africa was going to be a challenging exercise. It's something we knew right off the bat, given that the virus that causes COVID-19, SARS-CoV-2, is a new virus. So its pathogenicity is just emerging. In general, there are very few data sets associated with Africa. Large swath of the population was presenting either as asymptomatic or low levels of infection, which means even the reported case numbers at the best was just a fraction of the true picture. Beyond that, the drivers for morbidity and mortality for COVID are very limited. In fact, they're just linked to age and underlying conditions. But despite this, we did build a covariate model for COVID-19 in Africa, including 11 variables across epidemiological, social demographic, and health preparedness variables. We overcame some of the challenges I just spoke about by combining 3 unique features into our modeling exercise. So firstly, we curated data from 193 countries globally, and then used statistical relationships to fill in the gaps, data gaps for Africa. We also modeled a unique factor, which we called an expansion factor, which was unique to each country in the region and described within the time frame of the model how the virus was expanding within the given time frame. And thirdly, we were very adamant in ensuring that we did vigorous testing of our model, and we calibrated it by using out-of-sample data sets. So this was the first paper of its kind. And what the results showed was that during the initial phases of COVID, connectivity would be the main driver through Africa, though Africa has a low mobility index. And now this can be explained in terms of urbanicity and a high social demographic index. At the population level, infections were going to be below 1.5%, and even at very high infection scenarios, it was very unlikely that more than a quarter of the region's population would get infected. Beyond this, we did project intra-regional differences, with Southern and Northern Africa being the most impacted, Eastern Africa region being the least impacted. Hotspots identified included South Africa, Morocco, and Algeria. And yes, like the rest of the models, we also picked up the millions of projected infections and mortalities, but that's something, I'll be happy to discuss later. So what this told us off the bat was that a one-fit solution wasn't going to work for Africa. African leaders and governments needed to adjust their programs and policies. And indeed, Africa did a good job of balancing interventions with the need of maintaining livelihoods and social cohesion. And one way this was achieved was by adapting physical distancing measures, as shown by this policy piece out of the Africa Academy of Sciences, the AAS. So examples of adaptations to physical distancing measures includes curfews such as those implemented in Kenya. Ghana restricted movement at hotspot areas. Nigeria practiced temporal distancing, while Senegal allowed continuation of its public transportation within new guidelines. And these are just a few examples. So at the same time, we at the AAS were very focused in delivering on what the research agenda would be or should be for the region. So we engaged with 1,000+ scientists and policymakers from the region in an open survey to develop a priority list for research and development that supplemented the WHO coordinated global research roadmap. And the outcome was 17 new priorities specific to the Africa region, including the need for building protocols for clinical management of COVID in the absence of intensive care units. These findings have been, in collaboration with our partners, the UK CDR, the Africa Union Development Agency, and the Global Health Network, have been translated into Portuguese, French, and Spanish, and now not only inform Africa's research priorities, but also the priorities of low middle income countries. At the AAS, we also developed a database of COVID-19 experts, leveraging on our AAS clinical trials community program, and we've raised $3 million and ongoing in funding for these research agendas. So what have been the lessons for African building resilient health system? If there's one message, it's health systems need to be resilient, agile, and equitable. No one person, no one community, no one minority can be left behind. After all, your health system is as resilient as your weakest link. The current model of healthcare is broken, which forces people to go seek healthcare because it does not take into account the structural barriers preventing access to healthcare. So a newer, more resistant model would mean healthcare comes to the people. Data complemented with local knowledge drives cost-effective choices, and as we can all appreciate, this is particularly important in resource-limited settings such as Africa. And lastly, but not least, community-driven initiatives needs to be leveraged. So how do we bring these lessons together? Mainly by two pillars. One, investing in research and innovation upfront, before an epidemic, before a pandemic, before an outbreak. And secondly, through decentralized, collaborative, open access health data networks can eventually become self-sustainable by acting as data analytic marketplaces, and then working across these two pillars within the framework of transparency, mutual accountability, and the democratic principle of equity. And at this point, I'd like to stop and be happy to take any questions. Thank you.
Thank you very much, Uzma. That was fascinating. I want to also tell the audience that all of these presentations and slides will be available on the Wilson Center's event page afterwards, so people can review them later on. But Uzma, I'd like to just ask you a quick follow-on question that you were beginning to speak about a bit, but given your expertise and research, how do you see community-based health systems supporting the need for more research and innovation prior to disease outbreaks, as you were saying? And how can community-driven health be a part of the change that you're suggesting? A really big question, quickly.
Thank you for that question. So I think to the first part, to the first question, right? You have already given an answer to it. Community engagement has to happen before an epidemic. And I believe Dr. Malik, when she spoke, gave the other half of the answer. That question, that community engagement is just not a one-time activity. You do not go in when there's an epidemic or a pandemic. It's a long-term process, and I know researchers, including myself, have made this mistake in the past. But what happens if you engage constantly, two things happen. One, the community accepts responsibility and takes it as their own solution. And secondly, we as researchers learn to listen. And just to illustrate this, I'll give you two quick examples. So one example about researchers learning to listen, right? I was in part of the Ebola response in Sierra Leone, Liberia, and Guinea. We went out very confident with our health messaging. Don't touch bush meat, Ebola kills, come to the hospitals, right? And the question I got faced with, and I was totally stumped, was my grandfathers, my great-grandparents did not eat, ate bushmeat, and they didn't get Ebola. And if there's no cure to Ebola, why should I come to the hospital, right? So it just changed our mindset. And another very quick example I'll give you is from the work out of the AAS. So at the AAS, we support sponsor science on the continent, and we're big on supporting community engagement. And one of the programs I manage, the Deltas program, which is across 54 countries in Africa with 4 different partnerships in Europe, across $100 million. We provide seed funding for community engagement. And one of my favorite examples of impact from this work is one of our consortia out of Tanzania that works on HIV and fertility. We had a PhD student who was a recipient of our seed fund for community engagement, did his research, got his research findings, went to the school district and engaged with the students and said, these are my findings. This is what's going to impact you when it comes to HIV and fertility. What are the solutions? They co-produced the solutions, and then, this is even the nicer part, they got an art director involved who actually taught the students how to put up a skit for the national drama series in Tanzania. The skit was judged by the peers, who then adjusted the solutions, and now the solutions are going to national level to inform HIV and fertility issues in Tanzania. So that is the impact of getting communities involved and listening.
That's amazing. Thank you. Thank you very much for sharing those examples. That's incredible. Thank you.
Thank you.
Okay, and now we are going to go to Dr. Raj Punjabi from the Last Mile Health. Raj, welcome. The floor is yours.
Thank you, and just want to say how inspired I was by all of the incredible contributions, and I think my comments will presentation will largely complement what's been said. Outbreaks start and stop in communities. We've heard that already, and the role of community health workers, as we heard from my brother, Dr. Mohammed, are just absolutely vital. And it was true for the everyday epidemics. It's even more true during pandemics. Ambassador Malik and I actually, like many of you, saw this firsthand in West Africa. And I want to make this point about patient 0, Emil, who was a 2-year-old in December of 2013 in the forest of southern Guinea, who fell sick with vomiting, fever, and diarrhea. And his parents and family thought that may have been the run-of-the-mill type of condition. But then he died a few days later, and his mother died, and his sisters died. And this disease spread like wildfire from one village to another. And it wasn't until 3 months later, in March 2014, that the world recognized this epidemic of Ebola. When every minute had counted, we know that months passed before we mobilized a response. Several more months passed as this disease spread through my country and the ones near it, Sierra Leone and Guinea. Well, it was in that moment when we were told that over 1 million people could become infected. This was before the vaccine was available, that most of those people would die. When we had nearly lost all hope, that it was local community health workers teaming up with frontline nurses who, when Ebola threatened to bring humanity to its knees, stood up, learned the signs and symptoms of Ebola, went door to door with doctors to find the sick and get them into care. And as you heard from Ambassador Malik so eloquently, they were critical for helping halt this epidemic and stop it in its tracks. We've learned a few things from these workers. We've learned that the courage, the love, the connection of people to their own communities is an incredibly vital asset that we all depend on, because it's effective, but also because it allows us to move quickly. And if there's anything about an epidemic, is speed matters. And so does investing in people closest to the problem. That is the root of resilience, as we've learned from those community health workers then, and the many that have responded to epidemics across Africa. The second thing we learned from the West Africa Ebola epidemic, and what we're learning now from COVID, is that epidemics don't only threaten our immune systems, they can devastate our health systems. This is data this is actual data, not projections from that time. And I emphasize that to say, because we had also made, all of us, projections that this would happen, and then it happened. 140% of malaria cases amongst children went untreated across Liberia. And there was an increase in maternal deaths across that region. This is happening now again during COVID, but it doesn't have to be this way if we are investing, as Uzma so eloquently said, every day in these programs. This is the power of what could have happened in Ebola and what can happen now during COVID, as different as those two epidemics are. Facility-based delivery, skilled birth attendants across Liberia dropped. It wasn't very high in the first place at the time in 2014, slightly above 50%, but it plummeted threefold during the epidemic because our health workers were becoming infected, our health systems had poor infection control, and people were afraid to go to the hospital because they were afraid they'd get infected. In fact, we documented this in a study. If you were even in a low transmission area for Ebola, and you were a mother, an expectant mother, and you believed you could get an infection from a health worker in a health center, you were about 50% less likely to go to that hospital for your birth. That didn't have to be this way. In places where the Liberian government had already invested in hiring, training, and equipping community health workers, linking them with primary health centers, ensuring they are supported by nurses to provide routine everyday care, the government was able to adapt its protocols. It didn't tell the workers to stop working, it provided them with protection. It didn't tell the workers to sit back, it actually provided them with the payment they needed. It didn't tell them to sit back, it provided them with the training and support they needed. And they were able to sustain facility-based deliveries and treatment for sick children with conditions like malaria in those areas. The importance of persistence, not to repeat this vicious cycle of panic and then neglect, but a virtuous cycle of commitment and effectiveness and impact, is what the Liberian government stayed focused on after our epidemic came under control. Ambassador Malik played an essential role in this, as in supporting the leadership of the country, President Sirleaf at the time, who made a commitment that she would deploy a health worker, community health worker within reach of every last community in the country. That was about 4,000 workers in the country. And she made that commitment to do it before she left office, to deploy half of those, and President Weah has continued with his government. Those workers have provided everyday health care. They've provided treatment for children. They've provided prenatal care, but importantly, they've also continued, and the first thing they were trained on was event-based surveillance. And we've seen that again and again. When we have the eyes and ears of the health system closest to the people, we can have a stronger emergency system. And that might be the other big lesson we learn from these workers in this experience, is that the best emergency systems aren't emergency systems per se. The best emergency systems are everyday systems that can surge at times of crises. This is relevant today, as many of my colleagues have already said. When you've seen one pandemic, as we say in public health, you've seen one pandemic or one epidemic. COVID's very different than Ebola, but there are some similar approaches that are critical. The first challenge in COVID is how do you achieve rapid and sustained viral suppression? This is from our colleagues at Resolve to Save Lives. And we know that the work of testing and tracing and treatment and isolation, as my colleague Mohammed said, is vital. Juliet repeated that. We need to build those systems. Community health workers are critical for that. The second is how do we prevent primary healthcare system collapse? You heard about the projections of COVID from USMA. There are also other projections that show the impact on disruptions from COVID on primary healthcare, including a 30 to 40% increase in low and middle income countries, many of them in Africa, from excess child and maternal death, non-COVID conditions. But it doesn't have to be this way. If we invest in the people closest to the problem, if we build those everyday systems every day and surge them during times of emergency, then you can see results. Across Africa, this is from scientific papers, those countries like South Africa who invested in these workers, they had about 27,000 HIV and TB community health workers who they retrained. They went on to screen and help detect COVID at the community level, screening over 11 million people, about 20% of the population in the first months of their pandemic. In Ethiopia, their legendary health extension worker program has provided primary health care. And during the COVID pandemic, those community health workers have traced thousands and tens of thousands of people to ensure that they are connected with rapid response teams. And they've leveraged digital technology on training for contact tracing and infection control to do that work. And in Liberia, the place that I just mentioned had made those investments after Ebola. When this next pandemic is hit, kids have not gone untreated for malaria. In fact, we're doing an analysis now in support of the government that shows 1 out of 2 rural children in the country with malaria are being tested and treated by their neighbors, by community health workers who are paid and supported and supervised. And that treatment has been sustained during the pandemic. All of that treatment is continuing. In fact, it's slightly more than what's even being delivered at the healthcare facility level now. So my call to action to this group, because I know there are many in this community that are watching that are in the security community, the international development community, they go beyond our global health community. I have a plea and a call to action to offer. We need your help to make the case that investing in these community health workers, as Mohammed said eloquently, is not simply a health issue. And because that is so plainly clear now, it has devastated our health systems, our economies, it's been an issue of national security. At this moment, when we have the political leadership more engaged than they have ever been, the Bureau of Africa Heads of State meets every few weeks now on this issue. At this particular moment, we need your help to do one major thing, to shift the idea that these workers should be volunteers and informal. Most of these community health workers are women. Most of them are from poor communities, and they go unpaid. We have a guild mentality that tells us that these workers should remain under-recognized and undervalued. We'll ask them to volunteer when it's needed, and that is devastating. We have framed that as a healthcare issue because we know when we pay these workers and you support them with the supervision, you get better health results, but you also get better protection of livelihoods during a crisis like this, as you've seen. So what we need is to get behind the Africa Union's effort to scale up 1 million community health workers. What we need your help on is to push for these workers to be employed as a job creation activity. We should not be increasing domestic financing of healthcare simply from healthcare budgets. And what we need is investing fiscal stimulus packages. We should invest security budgets into this kind of a workforce because it delivers for the economy and the security of nations. I'll make one simple point here. The UN Economic Commission for Africa pointed how within reach this is. The UN Economic Commission for Africa put out a analysis in April that showed at least $100 billion of fiscal stimulus would be needed to support the economic recovery in Africa and mitigation. There have been some debt relief that's also been passed. Just 2 to 4%, just 2 to 4% of that minimum number of $100 billion would help Mohammed help the member states fund this workforce, this potential pandemic health force that could help us not only deal with this pandemic, but be better prepared for the next one. Thank you.
Thank you, Raj. You spoke a lot about investing in people closest to the problem. I really like that sentiment. And I'd like to follow up with you also with a follow-up question, just to talk a little bit more about the economic case for investment in community health workers. If you could just, yes.
Sure. Yeah, you know, the economic case is quite clear. There was an investment case that was developed a few years ago by Prime Minister Hailemariam, as well as President Sirleaf, the World Bank, the USAID, a number, the WHO have all supported it. Science is pretty clear. For every dollar we invest in hiring and paying the worker, supervising and supporting the worker with the equipment she needs, there's a $10 of return to the economy. And that comes from the things you might expect, such as protecting us against the next outbreak, such as extending healthier, productive life years. But it's also one of the fastest ways to create jobs for young people on the continent. And every politician right now is struggling, not just with the health impact of this, but with the unemployment crisis. The fastest way to create jobs, one of the fastest ways, would be to train hundreds of thousands of your own people to be able to do this within, and the trainings are not long. This is, you know, anywhere from 6 weeks to a couple of months to get people fielded. And they can all start with focusing on surveillance, because that's absolutely critical right now.
Thank you. Thank you very much.
You know, if you look at the math, please, go ahead. Yeah, sorry, if you just look at the math, it's kind of shocking. I mean, you know, and I'm so glad Ambassador Malik is here, because we need that political leadership. And Juliet from WHO, I know you all have been saying this. We need solidarity, we need equity. And it's not just the right thing to do, it's a smart thing to do, right? It's cost trillions, literally trillions of dollars, more than what was ever projected a pandemic would cost. This is simply a few billion dollars to deal with avoiding trillions of dollars of economic losses, not to mention the loss of life, which is not even able to be estimated in terms of dollars. That's just sacred.
Thank you. Okay, so now we've just seen all of the presentations, and I will remind everyone we have several questions have come in from the audience, but if you want to send a question in, it's ecsp@wilsoncenter.org. We only have about 25 more minutes, so we are going to, I have some of my own questions, and I'm the moderator, so I get to ask those first. And we're just gonna go through them. You don't have to rush, but we'll just kind of go through them one at a time, and then I'll get to the audience questions, because there are several already coming in that are interesting. Juliet, I'm going to start with you. Can you speak to what role, and we were just kind of, Raj was just talking a little bit about this, but can you speak to what role trust plays and how trust is built between communities and governing bodies? And how do you see international organizations like the WHO contributing to that necessary trust?
Thank you for that question. I think trust defines all that we do. When we talk of health sector development, and I'll start there, I mean, the reason we went into all these sector-wide approaches, one plan, one M&E, is it was premised on trust, trusting the government to do the right thing, trusting partners to honor their commitments. And indeed, when we lost trust, we suffered setbacks. For example, countries that set up pooled funds, we saw partners leaving those pooled funds to set up other mechanisms because trust was broken. Governments didn't honor their part of the commitment. Now, when we talk of health sector development, when we talk of UHC, we talk of rallying actors around a common vision. And again, their trust is important, that you trust the conveners of the meeting, you trust the stewards of the sector, to be working in the good faith of the communities that they serve. And today we are talking about building resilient community systems. Why are we putting communities at the forefront? interventions taken up by the communities, and the messages will also be accepted by the communities. People accept things if they come from the people that they trust. But now I want to touch on the issues. What have we done as WHO? I think we've concentrated on 3 areas. One, to train countries on the how. How do you do it? We've provided tools, we've provided frameworks, we've provided guidelines. We've also concentrated on the what. I mean, we've built capacity. We've also mentored ministries of health, and not only ministries, by the way, all partners, civil society inclusive. You know, the art of building trust, the art of engagement, the art of dialogue, and in those soft skills to make sure that there's trust for people to work as one team to pursue a common vision. But also we've brokered relationships. You know, we've been conveners, bringing people to the policy table, bringing people together, trying to handle issues of conflict of interest, bringing transparency in systems, in priority setting, in dialogue. So I think trust defines all that we do, how we work, and how we engage in relationships, whether with the communities, with the partners, and also even within line ministries. It also comes in when we talk of multi-sectoral collaboration. Thank you.
Thank you very much, Juliet. I'm actually going to make a little bit of a hard turn here and throw it to Mohammed. When I was reading your bio, I mentioned your work in psychiatry, and I'm curious as to the effects that maybe you've seen to mental health around the COVID-19 pandemic, and if you could share some of examples of past interventions to address mental health during public health crises that could work towards COVID-19.
Thank you very much, Sarah. In Africa, the effect on mental health has been quite enormous. You know, in the continent has a huge amount of people living below the poverty line, people who have to move out, go out daily to bring food on the table. And suddenly you have a pandemic that and a response that says don't go out, lockdown. Africa was very quick to lock down, and that's one of the reasons why we say why we think maybe the continent has been spared some of the what we thought will have come. However, that action in itself was a lot on a lot of people who have to go out to bring food to the table. It led to a lot of stress within the family, within the community, and we'll be dealing with some of those consequences for a long time to come. Also, the lockdown brought in some component that we may not have completely anticipated. There was increased cases of abuse, intimate partner violence, people who will ordinarily not see each other until maybe in the evening. Everybody goes to work and come back in the evening. Now are locked down 24/7 for 1 week, 2 weeks, 1 month. And we saw, and the data is really coming, increased rate of intimate partner violence, rape, really targeted mostly at the female gender, which is really, really unfortunate. And you know, the women and in Africa are some of the most enterprising and hardworking. They go out, they bring food to the table through their very hard work, and now they can't do that, and so many other factors. The physical and social distancing method that was used to control one of the best method for control of the outbreak, also it will impact on the mental health of Africans. We are very used to mixing in our community, going out, visiting, and stuff like that. So yeah, we know that the physical and mental, especially the mental component of this, we will continue to deal with it for a long time to come. Some people have been scarred for life. we've seen it. It was all over in many countries on the continent. Especially, I was in Nigeria during the lockdown, and I noticed it was a huge issue. It was disturbing, especially for those who were locked down away from their family, their children in other parts of the country. It was a huge mental stress. So for some interventions that in the past that has worked for mental health during outbreak response, I think one of the best I can think of is the agency standing committee guidelines on mental and psychosocial health of that was taken done in 2000 way back in 2007. The guideline helped to plan, establish, and coordinate a set of minimum and multi-sectoral response to protect, support, and improve the mental health and psychosocial well-being of the community in the midst of an emergency. That was very helpful. That was before Ebola. Post Ebola, I know the WHO mandated that mental health and psychosocial support should be part of all cluster meetings and preparation for emergency response. That's a very good mental health intervention. And the WHO program for mental health to especially in Africa, we know we have a lot of shortage when it comes to community health workers, and the MHGAP program that seeks to bridge the gap in this health care workers, mental health care workers, has been very helpful in improving an otherwise neglected component of any pandemic or outbreak, even in the best of health systems in the world, but most especially in Africa. Thank you.
Thank you very much, Mohammed. And you touched on so many different topics that I'd love to dive into, but the one that I'm going to focus on now is really looking at women and even girls and the impact of COVID-19. And particularly as I direct the Maternal Health Initiative, I want to turn the conversation briefly to maternal and reproductive health. And actually, I have questions and I'm going to throw it out to Raj, but we also have 3 of our audience members have also sent questions on both maternal health and reproductive health. And so I'm going to read one of those and Raj will ask you to respond to that one, okay? This is from Bob Walker, actually from the Population Institute. He said it was mentioned the impact of excess maternal and child deaths in African epidemics. Do many or most African governments and health advocates see rights-based reproductive health care and voluntary family planning as essential components of universal primary health care in the work of community health workers? If not, where do these components belong in African community-based healthcare, and will access to them suffer as resources are directed to addressing COVID-19 and other health crises? And Raj, I would just throw that to you. I know that I've read the people are talking of increase of 30% of infant and maternal deaths due to COVID. So I would greatly like to hear your response to Bob's question.
Bob, thank you for that question. I think there's a lot more that needs to be done in this area. Some of the best programs, as you probably know, across Africa, take Liberia's program and Ethiopia's program, which has now been recognized by Bill Gates and the Gates Foundation through their exemplars in global health program. Rwanda is another example. They have, in their employment of these workers, because they formalized them, they've been able to shift caregiving roles, including providing contraceptives. So oral contraceptives are one way, but in Liberia, I was there when I was there a few months ago. Some of the community health workers now are being taught to administer injectable contraceptives like Cyanopress, which is many know is a self-injecting contraceptive. In Liberia's case, they've decided to ask the community health workers to administer it, allows 3 months of contraception, and especially for rural mothers and rural women, a chance to take more control of their family planning and birth spacing, and also a chance to decrease costs because they don't have to travel hours to the clinic or hospital to go get the injection from there. So we need more of that. During this crisis, what happened is that the countries that had those systems that invested not just in the services like reproductive health, but the systems. And we like to think of sort of 4 S's, the skills to support those workers. So there was a training system in place, the supervision structure. So all of the workers in Liberia and Ethiopia are supervised by clinicians like nurses and midwives, dedicated supervisors. The 3rd S is the supply chain. So there's a regular supply chain for all kinds of medications and supplies, including PPE. And the 4th S is salaries or a version of that, some sort of compensation. If you invested in those 4 S's, and what you did is you didn't say stop contraceptive care by community workers, which has happened in prior epidemics and in places where those systems are not invested in. They actually said, let's adapt those systems to continue contraceptive care during this pandemic. So the workers in Liberia all got masks and gowns and gloves and the PPE they needed. They had a change in their algorithm. You know, they've been physical distancing, and some of them switch, you know, if you don't have those things in place because PPE shortages come up, then you switch to oral because you can keep the distance from the patient, but the woman is still able to access the contraceptive she needs. That kind of agility is, to me, what measurable resilience looks like. And I think that not enough of that's being prioritized in most of the countries. I think these are still exemplars and exceptions, but they need to be absolutes and universal.
Thank you. Thank you very much. And just a correction, it was Bob Engelman, not Bob Walker from Population Institute. There's 2 Bobs there. Uzma, I want to throw a question to you, and then we only have about 10 minutes left. So then we'll ask another question from the audience. But Uzma, I wanted to ask you this. And we talked about this a little bit on the speaker call last week, but there's been 3, maybe a couple more, but 3 commonly cited reasons for some countries in Africa doing well during the current pandemic that I've seen. One is Africa is characterized as having a young age structure. So in countries where there's a larger percent of the population is over 65, like in South Africa, COVID-19 death rates have been much higher than in other countries that have a younger demographic. Second, at the beginning of the pandemic, as many people have noted, many African countries enforced strict lockdowns, movement restrictions, border closures, contact tracing, testing, and quarantines, which may have prevented or at least delayed the spread of the virus throughout the continent. And third, past epidemics, most notably Ebola, forced African countries to create systems and collaborations that allowed them to respond quickly at the start of the pandemic. You all have spoken to public-private partnerships, collaborations with international organizations like WHO, and inter-country collaborations. These are all things cited. And I'm just curious, Uzma, do these points resonate? Do you agree with these things? Are there things that are left off? Are there things you absolutely disagree with? I would love to hear your thoughts.
So let's tick the boxes and say yes to all, right? There is data that, you know, the elderly, in fact, the above 80 are 100 times more prone to a mortality to COVID versus the under 20s. Yes, Africa's median age 19 compared to Europe, the average age is half, okay? But Africa is not one of the youngest populations. Middle East is, right? The whole idea, there's an idea around pre-existing immunity. And, you know, I started off by saying 20% of the global disease burden in Africa. Yes, there is data coming out from the BCG vaccinations that earlier vaccinations have positive outcomes. True, right? But we do have infections in the subcontinent, so it doesn't explain the whole picture. Ebola, yes, right? Juliet's talked about this, Raj has talked about this, Abdulaziz has talked about this, all the examples that we've used and more, right? And we should even go beyond to that, right? Africa learned lessons from the HIV pandemic. The whole idea of getting context came out from the HIV pandemic, when we knew the most efficient public health programs would be inefficient if local context wasn't in place. So yes, but there's still this big gap that's unexplained. And let me put this hypothesis forward to the panel and to the rest. How about, you know, Africa leadership got it right? Right? And when I say Africa leadership got it right this time, what does that mean? It means that we, the leaders of Africa, or our leaders, saw it for what it was. It was a public health emergency. Hence, they acted on it and did all the right things fast, versus, without taking names, some people who think it's a political issue, right? And what happens when leadership steps up? Communities step up. We've all talked about this, and African communities are resilient and they're innovative. I'll give you an example from my home country of Kenya. The Economist, a few years back, wrote an article citing Kibera, which is the largest urban slum, as the most entrepreneurial place in the world. Communities kicked in because of leadership. And then one thing that I haven't seen a lot discussed, and I think is a really important factor, is Africa as a whole has maintained its social fabric of our neighbors, of our friends. Raj talked about this, closest to the problem, it's your neighbor treating you, right? And what this means is African communities have social capital, have social networks, which have kicked in. And, there's literature from every field, right? From leadership of what the positive impact of social capital is. There is positive impacts from the fields of management, economics, healthcare, right? Aziz was just talking about mental health. We know the impact of having the social capital and the positive outcome of that. So I'd like to suggest, let's put forward the hypothesis that Africa got it right. Right? It's not any golden bullet. Let's change our narrative and see what happens.
Wonderful, thank you. I really like that. Thank you very much, Uzma. So we are almost out of time, but I have another question from the audience, and I'll actually throw it to Ambassador Malik first for her response. And then if others also want to respond very, very quickly, we will let you do that. So just unmute so I know you want to speak after Ambassador Malik. This question comes from Caroline Hart. In one way or another, you all noted the seriousness of public health as a necessary precursor to society's stability, security, and economic performance, and that health must be ensured by resilient systems and underpinned by multi-sectorial actions. What do you think prevents governments in Africa and in the United States as well, and other places, from making sufficient investments in public health that would reflect that importance? What do we need to do to persuade or convince policymakers, and what messages will resonate best in your experience?
Well, one of the first building blocks is this issue of trust, right? So as Juliet pointed out, if people don't believe their governments, if they don't believe their leadership, if they don't believe their local leadership, if the message doesn't resonate, you won't make any progress. But I think the challenge is that it's much sexier for governments to make decisions about investing in infrastructure, investing in big projects that people can point to and say, oh, look, we built this. It's not to say that infrastructure isn't important. It certainly is. But the critical piece is investing in the software, right? Not just the people, but understanding that, again, you can't talk about a robust and effective education system if you don't have children in school who are well fed, who can learn, and who will stay in the system and finish an education. Otherwise, if they leave or if they are subject to economic stresses in their families, girls are married off early, they become pregnant early, you have poor outcomes. All of these things are interrelated. And so it has to be a priority of the government to understand that without health, you can't talk about education or economic prosperity, that without health, you can't talk about empowering women and creating, mobilizing 50% of your workforce. Excuse me. So I think it's an ongoing challenge for all leaders to understand that they need to look at where the best and targeted investments are. We know from a development perspective, investing in women and girls' education is one of the best things that a country can do. A corollary of that is investing in health systems that are robust and resilient. As you've heard from all the panelists here, there are ways to make that happen. And it has to start at the community level because they're the ones who are directly impacted and can be the most effective tools for ensuring that everybody has an equal chance in life.
Wonderful. Thank you so much, Ambassador Malik. Does anybody have a final second they want to say something? Go ahead, Mohammed. I see you already. Go ahead.
Just well, in 1 second, like you said, if Ebola taught us that investing in health, not investing in health will lead to deaths and massive outbreaks, COVID-19 is teaching us that not investing in health will deprive you of every other thing. Education, infrastructure, every other thing, and your society will really go back to square one. So, like we like to say in Africa CDC, investing in health security is investing in socio-economic security also. Thank you.
Wonderful. Does anybody else want to make a last comment? No? Okay, great. Well, thank you all. I could have sat here all day. I'm sure everyone learned an enormous amount from this conversation today. I know I did. Just a few housekeeping things. The event recording will be available on the Wilson Center event page. And as I mentioned, so will all the presentations and slides. Usually it takes about a day for that to happen. So it should be up there either later today or tomorrow. A summary of today's event will also be published on our blog, New Security Beat. And future events in this series that we're doing with Population Institute will discuss the progress of health outcomes and the status of women in Ethiopia, and peace, prosperity, and health in the Sahel in an era of forced displacement. Thank you to all of our panelists for being here today, and Ambassador Malik for opening us up this morning. And thank you again to the Population Institute for your continued support, and to everyone at the Wilson Center who helped make this event possible. And to all of you watching online, thank you very much for being here today. Stay safe and enjoy the rest of your day. Thank you all.
Thank you. Thanks, Sarah.
Thank you.
Everyone.